Good morning. Oops. Good morning. What I'd like to do today is walk you through a critical appraisal of a therapy article. And as you remember, one of the things that I've learned is, and been hearing some of the questions here, is whether or not I can help somebody spend £1 million Egyptian pounds is my goal. What I'd like to do is do the session. We're going to critically appraise a therapy article, and we're going to look for sort of the key concepts we did last week, randomization, allocation, concealment, and follow-up. And then we're going to calculate a series of number needed to treats, and to see if we can help the clinical scenario that I will present. So just to remind you, last week we looked at developing questions, and we defined that there was two types of questions: background questions where we need more knowledge, and foreground questions which are clinically relevant. And we specifically talked about PICO, PICO's problem, patient, population, the intervention, the comparison intervention, the outcome of interest, and the study type. And then on the second day, we looked at the second step of EBM. We talked about finding the evidence. I pointed out, and we had the opportunity to look at some of the quality filtered literature sources. We went to PubMed clinical queries, TRIP database, clinical evidence, and Google Scholar as examples of places to find information. Then we went through and did step 3, and we looked at both a therapy and a systematic review. And in therapy, again, we looked at randomization and intention to treat analysis and talked about those. We talked about the results of a therapy study, and we talked about applicability in the concept of a number needed to treat. And then yesterday we talked in background information about a systematic review, and we looked at its validity steps are different from what we see over here, because here you need to go through the steps of evidence-based medicine. Did they do a good question? Did they do a good literature search? Did they check the validity of the articles they chose? And then we talked about the concept of heterogeneity, saying that you don't need to know a lot of statistics to do this. You just need to look at the point estimates, the confidence interval, and then check that the statistics support what you believe you're seeing. So today, as I said, we're going to go through a clinical case scenario. We're going to talk about literature search. We're going to critically appraise out here in the groups, and then look specifically at the applicability and the number needed to treat. So as a physician, I was sitting here, and every morning I have my book and I write things down as I hear sort of questions develop. And that it helps me for two reasons. Is one, a lot of times the interaction is going on in English and in Arabic, and I just need to concentrate for myself, so I write things down, and I can write down the different points as we're going through. And yesterday I heard this whole question about, when I was sitting there, about the best way to use G-Csf. And there are varied opinions, and I heard lots of different questions in that handover rounds that I was at. And then I started to reflect on the questions that I'd heard, and I realized they're really similar questions to what I was hearing at home. How do we use G-Csf? When do we use it? How do we use it? Where can you use it? And things like that. So that's where I went, and I was thinking about a problem, a well-built clinical question. So thinking after reading that clinical scenario, what would be the patient, the population, or the problem being addressed? Oops, sorry. Neutropenia? Anything more about the patients? So they have neutropenia, anything else? Children with cancer? Okay. What would be the intervention then? So G-Csf versus and outcome? What are possible? Duration of neutropenia? Length of stay, hospitalization? Infection, recurrent infection? All really good outcomes. So that's what I just did. I just said, among children with cancer and febrile neutropenia who are to receive antibiotics, does G-Csf, and I called it, you could go no G-Csf or symptomatic care, lead to a decreased time with febrile neutropenia? And I thought that the best study would be an RCT. So I pumped in neutropenia, I pumped in G-Csf, I used the word colony stimulating factor only because that gives me a broader search, and I searched for RCTs, and lo and behold, I found this article here called A Randomized Comparison of Antibiotics with and without G-Csf in children with chemotherapy induced febrile neutropenia. And it's a report from the Children's Oncology group. So thinking about the PICO we just did, what can we talk about the PICO here? Can we see which population it is in this situation? So children, febrile neutropenia, okay, excellent. The intervention? So antibiotics and G-Csf, and the comparison? Antibiotics. Study design, outcome? Is there an outcome there? No. Yeah, this is the new way of writing where you don't put it in. And the study design? It's randomized. So it met the criteria that I had set out when I was looking for a question. And that's all I agree. And we're going to go on to critically appraising the article. So if Vivian could hand out the article, it's 7 pages. Just to remind, yeah, there's an exam at the end of this. But one of the first things we're going to do is we're just going to look at the introduction and find the hypothesis in the introduction, and then we'll go from there. We'll go from there, sorry. Vivian's also handing out a worksheet for you at the same time. So what I'd like to do is for what happened in this study, just so we're all on the same page to save you some time, is this was a study of children who were being treated for cancer in part of the Pediatric Oncology group or the Children's Cancer Study group, the precursors of COG, although COG monitored and developed the information. And what they did is they found eligible children. These were children with ALL or solid tumors, but not AML, because we believe that AML, the therapy there is much more intensive, so it may be a different group of people we're dealing with. And so they took these children from the different studies of institutions of the Children's Oncology group, and the children were randomized, were eligible, deemed eligible. So if you had ALL or other solid tumors, but not AML, and you could not have had G-Csf in the past 7 days, and you couldn't have been a bone marrow transplant patient, and then you were randomized to receive antibiotics or antibiotics and G-Csf, and then you were followed forward to see if you developed how long you were a febrile neutropenic. So, and then they broke that down to how long you had a fever and how long you were neutropenic. So there's 3 different outcomes. The primary outcome was the duration of febrile neutropenia, but the secondary outcomes were duration of fever and duration of neutropenia as separate events. And so they measured that outcome at that time. They did it by a bit more complex math than we're going to do here. They used hazard ratios, and they used censorship and Kaplan-Meier, but we're going to just look at it from a different point of view. So what I'd like to do is I need you to help me convince the person I'm going to talk to about this article whether or not the study is valid. So in groups of 2, so if you could just match up with somebody, I was wondering if, since there's 8 questions, if we could just, if I could ask this group on this side if they could do questions, and you can work together in a group of 3 or a group of 2 on the left side here. If you could look at questions 1 and 2, was the study randomized and was the randomization concealed? And then if there's this group here from Dr. Ahmed back, if you could do the second 2 questions, was there an intention to treat analysis and was the prognosis same between the 2 groups? And then if I could ask you 3 people in this little diagonal, if you could talk right here about the question, we're now into measurement bias. Were the patients, or parents, the clinicians and the outcome assessors aware of the outcome? And then I'm going to ask this group here, could you look at whether or not the follow-up was complete? And I'm going to ask up here again, if you could do the questions, was there an intention to treat analysis? If you, Dr. Samira and the lady sitting beside you could do that. And if you three ladies could do the second question, was the prognostic factor similar? And we'll just take 5 minutes to do that. So you don't have to do anything more than find the answer to that one question. And if you can take a moment just to mark in the article where you found it so that you can point us all and you can say which page it is and which column and which paragraph, and then we quickly can see it. So randomization and concealment of randomization. This group here behind Dr. Ahmed, intention to treat analysis and prognosis. This three here, if they could look at patient allocation concealment, follow-up complete, and that again. So just take 5 minutes. It's right now, it is 9:08, and at 9:14 we'll come back and we'll get the answers. Two more minutes and then we'll come together. So one more minute. Okay, let's move on here. So the first, remember again that on our worksheet, the worksheet's broken into two big boxes under the validity section. How do we select the patients to participate, or sorry, how did the researcher select the patients to participate in the study? And once all those patients had been selected and looked at, before you actually started the intervention, then once you've given the intervention, then how did you measure them? How did the researcher measure them? And did he or she measure them all the same way? So the first question was randomization concealed? So I don't know, do people over here have an answer for that? And I'll repeat it back. Was randomization concealed, and where did you find that in the article?
I don't think it was concealed because it's somewhat a patient-oriented study. So upon patient condition, growth factor may be given as intervention.
Okay, so again, there's a feeling that the allocation could be looked at, but that actually, remember that the very first question asks, was the process of randomization itself hidden? Could people tamper with the computer program? Could they tamper with what was going on there? Versus once the people started receiving the drug, could people figure it out? It's a very fine point, and a lot of times it's not written well in the article, so it's sometimes hard to pick out. Did anybody else have any ideas about that in looking at it? Yes, Dr. Henny? So actually, they don't state it here, but they did in the protocol that they did do what's called a power calculation, and therefore they could determine that there was a difference that they set as the difference in this situation. So it's a really excellent point. Was there enough patients participating? And I didn't talk about that a few days ago, but when you're doing a randomized controlled trial, as Dr. Haney was saying, you have to have enough people in the study, because if you don't have enough people in the study and you don't find a difference, remember when we talked about a randomized controlled trial last Wednesday, I think it was, we talked about that the real reason we're doing it and the whole reason we do randomization is at the very end of the study, we want to be able to say that the intervention, that if we see an effect or we see a difference, it was due to the intervention and not due to any biases. So Dr. Haney brings up a really excellent point, is that you have to make sure you have enough patients. And in the protocol itself, they actually did do mathematical calculations using numbers to determine the difference and the number of patients they would need to see. Is it? Sorry, I didn't. Which page are we on? 276. Page 276, column top right, first. Yes, okay, here we go. Study enrollment was to be 200 patients. They were sufficient to achieve. So they did do the power calculations in this situation, and they did account for doing an interim analysis. A lot of times when clinical trials are going on, you do an analysis of the data to see. If you do that, then you have to enroll some more people because you have to keep your power of your study up. So they actually did make that calculation, and they actually did an interim analysis and found a difference that was significant enough. So you can do it with different numbers of patients. You just have to make sure that somebody's done the background math on it. Yes. But then they calculated, they did that number and calculated if you didn't have 200 patients, if you did an interim analysis and you found out a difference that was so big, then you could have a smaller number of patients, and that's why they stopped the study early. There's another really important point with stopping studies early. It's not really a good idea in most situations, and actually there's extensive, if you Google Dr. Guyett and stopping studies early, there's actually quite a few studies that show where the difference, you really should carry your study out to the very end. And he argues it quite eloquently in an article in the JAMA that you shouldn't be stopping halfway because sometimes the differences do switch over again. So the randomization will have to assume it was concealed, because it was done by a study group, that it was done by a computer program. The second question was, yes? No, that's once you get, remember this is at the point before we actually intervene with the patients. So it's what's happening, that the computer up in the room up here is randomizing the patients. And then so it places the patients in the different groups. But once I start to give the intervention, then you get into that second group of questions. Mm-hmm. Well, then once they've met all those criteria to get the person, then boom, they end up in a black box. But that's just, that's called selection criteria. That's selecting. Sorry, Dr. Iman. Okay. That's selecting your patients. That's the process of selecting. There are, again, lots of articles saying that your selection criteria shouldn't be too complex. But if we go back to the example, I don't know if you were here a few days ago, but where we talked about the study of patients who had an endarterectomy versus aspirin, and if you randomize them very high up, then the surgeon was saying, well, you know, you're a good surgical candidate and you're a bad surgical candidate. So they should have put that in the selection criteria to select patients that meet the criteria that you would manage on. You bring up a lot of important points because in the applicability criteria, when we get to that point, that might be a concern, is that the selection criteria are too tight. But that's an applicability question because right now we're concerned about the people that have been accepted into the study, whether or not they got randomized and whether or not people could figure that out. Excellent points, everybody. So the second question was, were the patients randomized as well? So were the patients randomized? And you do see the words randomization. We just can't really tell if they're concealed. Did they do anything else in the randomization process? Okay, they did it by diagnosis. Good point. Remember how I said there's simple randomization and you flip coins and then there's complex randomization? Equal probability, yeah. Mm-hmm. So we should put here and also the number of patients. I do. When I answer the question, I put the number of patients. I usually jot a note, power calculation done, so that reminds me. So if the randomization happened, remember I said there's simple randomization where you flip a coin, and then there's complex randomization. And I said there's two types of complex randomization. Anyone remember that? They did one of them here, and they actually used the noun in the thing. There's stratification, and they did stratify. And how did? Mm-hmm. So they stratified people by a variety of things because they thought all these different stratifications could be risk factors. So hematological malignancy compared to solid tumor, never relapsed or progressed, no source of infection as well. So those are stratification. And then there's something called blocking, which they didn't do, which you usually only see in pediatric, smaller pediatric trials. So we said there was randomization called equal probability. We said we could say there's not a definitive statement that the randomization was concealed, but we could say it was done by a study group, so instead of saying yes or no, you could say maybe. And the next question, were the patients analyzed in the groups to which they were randomized? Does anybody remember the words you need to look for that sort of should set up a little flag? What are the words when you say intention to treat analysis? Great. So was there an intention to treat analysis? I believe that was over here. And what page did you find that on? 276? Whereabouts? Sorry. In the... Sorry, you can help me? Very first page. In the abstract. Okay, that's that was a previous study. What about this study here? That was the study that they're reporting on in adults. Which did anybody find the words in here? In statistic, which paragraph are we looking at? First one. Mm-hmm. So thank you, Dr. Samira, because some people don't always write intention to treat analysis and they use different words, and here they've done that. So you have to, intention to treat analysis is what you should look for, but all comparisons were according to assigned treatment regimens, which is similar to saying intention to treat analysis. So we said the patients were randomized, yes. We said the randomization concealed, we said maybe. We said the patients were analyzed into groups to which they were randomized. We said there was an intention to treat analysis. And the last question was, were patients in the treatment and control groups similar with respect to known prognostic variables? And where do we look for that? Were patients in the treatment and control groups similar with respect to known prognostic variables? Table 1, yes. So Dr. Iman and down here, if people would take a look at Table 1, which I've put here. So is there anything that you're concerned about? This is the antibiotic group, this is the this is the antibiotic plus the G-Csf group. Caution about this here, we'll talk about this in a second. Were there any ones that people were concerned about? Looking at that table, anything you would... Hispanic, 11 versus 4. Anything else? So what you're doing is you're looking quickly down. This table actually has a p-value in it. I'm just going to give you a caution. You don't usually, by convention, see p-values in Table 1s. The reason is this is a post hoc calculation. This is calculated after the study has been completed. It's not done beforehand. These two patients, this is a statistical test to see if there's a difference, but because I randomized, this distribution of patients happened by chance alone. So it doesn't really, need a p-value. This happened by chance alone. They were randomized. That's the way things fell. So a lot of studies that you read will not have p-values in them. They won't have it here. They'll have it in the paragraph underneath the article. But just a caution, this isn't a statistical test that's done beforehand. This is done after the study's been done, and this happens because the study... But what we need to remember is that we have randomized the patients, and our whole idea behind randomization is things like this happen by chance alone. That's what randomization does. That's why we use it.
What does it mean for Fisher exact test to have 0.11 in the ratio?
Down here?
Yes.
So right down here, there's... What they did is, because it's such a small difference, they did a Fisher exact test. When you're working with small numbers, you should use a different statistical profile, so use a Fisher exact test here. It's just that. Any other questions? So again, we said the study was randomized. We said maybe on the randomization being concealed. We said there was an intention to treat analysis. And lastly, we said that overall, things are pretty equally distributed by chance alone. So now we need to go start measuring the patients. So were the patients, the clinicians, and the outcome assessors aware of group allocation? And where did you find that in the article? Did anyone? Okay, so people could tell by which disease they had, but could people figure out who was getting G-CSF and who wasn't getting G-CSF? What if you had a patient on the ward and you were giving G-CSF to one and not to the other, do you think the patients could figure it out?
No, but if it is a trial like this, there must be a consent form.
Okay, so there's a consent form, but so I consent. So I consent my patients here. Two patients have agreed to be on this study, and they're in the same room together up on the yellow floor. And they're in the same room. One's getting G-CSF and one's not. Do you think the patient could figure out who was going to get the G-CSF? Okay, so they did do an informed consent, so the people knew they were on the study. But actually when I'm giving the intervention, could people figure out who was getting G-CSF? Would the nurse know who was getting G-CSF and who wasn't going to get G-CSF? Would the doctor know? Would the patient know?
You mean they are not going to know the randomization, but the nurse will know that she's going to give.
Exactly, and the kid's going to know because he's getting a needle and not getting a needle. So one's crying because he's getting a needle and on the same study and the other child's not. So they can figure it out. Yes?
It's not clear that they were, I mean, they could have been isolated from one another or the ones who were getting G-CSF.
So I've got this big needle with G-CSF in it and I'm coming towards the patient. Do you think he knows that I'm going to give him G-CSF or not?
The ones who were getting G-CSF could be together in one room and the ones who were not, they could be separated from each other.
Okay.
They wouldn't necessarily know, they wouldn't know what they were, necessarily getting. So
But if,
the child, we don't expect them to understand.
so in that case the parents, would the parents know who's getting G-CSF or not? Would the parents know if their child was getting G-CSF or not?
It's not clear in the, I mean, unless the consent form says which group.
In real life. Because that's what's happening. Like this is a summary of what's happened in real life. Of course they know. Yeah. I mean, what else I'm saying is that if this child here is getting G-CSF and I'm the nurse or the pharmacist, I'm drawing it up so as the pharmacist I know. I'm the doctor standing at rounds watching the nurse with the needle going into the room and I know she's giving the G-CSF to my patient. I'm going to know that my patient got G-CSF and the patient's going to know because they're going to have the sting from getting the G-CSF. And then in the next room, as I have a patient who's on the study and he's not getting G-CSF, I don't see the nurse go in at the same time with the needle. I don't see the nurse isn't giving it, so she knows this child is on study because they've completed an informed consent, and the parents know that my kid's not getting an extra needle each day. Does that make sense? Like that people could figure out. So people could figure that out in that situation. So the people giving the needles, the people definitely getting the needles are going to figure it out, and then the person who assesses the end of the study, could they figure it out? Assessing the study, assessing how the people did, whether or not they had a fever or whether or not they had neutropenia. Yeah, I'd agree. That's probably a bit more difficult because they may just be numbers that are sent to Acadia, California, where the data is kept. Like I might know, I might realize that I'm discharging patients 9 days earlier than if I'm not giving them G-CSF. So in this case, once the randomization process has happened and once the intervention's been given, people could start to figure out what's going on. Not bad. That's the reality of doing a randomized control trial. But you have to just remember, could bias come into the study in those situations? So the last question was follow-up complete? Did all the children who entered the study, did we know what happened to them? Mm-hmm.
So can you say that this is a follow-up?
Yes, because we're just following to our endpoint that we've decided. Now they did say in the discussion, and I think that were looking at secondary outcomes, and they couldn't gather all the data because they stopped the study early because they were going to follow patients longer. So follow-up was complete. So overall, on a scale of 0 to 10, where 0 is the worst article you've ever read that's a randomized controlled trial, and 10 is the absolute best, what sort of number would people want to give this study? Just put a number in your head. And what do you think, compared to the other articles we've read in last week? Anybody want to give it a 0? Anybody want to give it a 10? Anybody want to give it a 6, 7? 7? You're more generous this time. Mm-hmm. 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 Excellent point. What was said here is that we don't really know when the patients came into the study, and we don't really know if that makes a difference on how the study was run. Those are all good questions. Again, those are applicability questions. It's not the little concept of validity stands, but you bring up excellent points about whether or not we should actually apply this to our patients, because maybe the patients weren't the same at different times. Maybe some were in induction and some were in maintenance. Maybe that's different. Now, they did take out the AMLs, because we know AMLs are different with febrile infections than ALLs. So all really good points. So 6, 7, anybody want to give the article an 8? So we're sitting around 7, 6, or 7. Okay. Okay. So what I'm going to do is work through the results with you and just show how to take the results. Now remember I said that the results were rather complex in the sense that they used some statistical techniques, and they used something called Kaplan-Meiers and censoring the data. And a lot of times it's hard to extract information from that to do a results. So what I'm going to show you is a little technique. It's not as exact or as wonderful, but it may give you numbers that you can use yourself. So if you look at figure 1, I think it was, yes, figure 1, time to resolution of febrile neutropenia according to randomized treatment regimen. So here's our outcome, febrile neutropenia. And on the x-axis, it's the number of days that you had febrile neutropenia and the proportion with febrile neutropenia. So this means at the very beginning, at day 1, 100%, or day 0, 100% of people had febrile neutropenia, which would make sense. They have febrile neutropenia. That's how they got on the study. And then you'll notice in this group who just got antibiotics that their resolution of febrile neutropenia took a lot longer than the group here who had G-Csf and antibiotics. So what I'm going to do is make an arbitrary decision that I'd be interested, I would be interested in looking at febrile neutropenia at 10 days, because that's a pattern, and I'll do 7 days in a few minutes just to show you the difference. So all I did to take this data from being using statistical tests, just see what I could find on the graph itself. I said that's where I thought about 10 days was. I just ran a line directly up, and I ran lines across where the lines were. And so I thought that 52% of people who were getting just antibiotics still had febrile neutropenia at day 10, but in the group that were getting G-Csf, in addition, that was only about 15%. And then I calculated that as a 2x2 table. Again, remember, the way you set up the 2x2 table is using PICO. The patients go in the boxes, the intervention on the side, and the outcome on the top. Because the answer that we're looking for, the true answer is on top, we're looking up. So then I said, do you have febrile neutropenia at day 10 or do you not? And I took the point off the graph that I saw, so 52% times 34 and 15% times 32. And I got these numbers here. So I got 18 in the antibiotic group alone, and in the group that got antibiotics and G-Csf, I only had 5 patients. And then I calculated the relative risk reduction, which is 0.71, an absolute risk reduction, which is just the difference between the risk in the control group, so the group that just got antibiotics, subtracting the risk in the group that had G-Csf. And then I did a number needed to treat. So just remember that. I'm going to give you another, I did it also by a computer program, and sorry I didn't put the website on here. It is www.CEBM, Centers for Evidence-Based Medicine, UToronto for the University of Toronto.ca. And all you do is you set up your 2x2 table like we did back here, pump these numbers in, and it does all these calculations for you very quickly, and it gives you a 95% confidence interval. So let's just look at the number needed to treat. It's 2.68, we would round that up to 3, but the 95% confidence interval goes anywhere from 2 all the way up to 6. Does anybody remember how we're supposed to say number needed to treat? We're going to use PICO, but... So I would need to treat 3 patients with febrile neutropenia. I would need to treat with G-Csf to see 1 patient improve. So I only have to give G-Csf to 3 different children to get 1 children that gets better than if I hadn't given G-Csf. Is that a number that would be of interest to you? Do you think that would indicate that you should use G-Csf? Okay. Yeah. So for the situation where we have arbitrarily chosen the outcome to be febrile neutropenia at 10 days, we could reduce the length of febrile neutropenia significantly, that for every 3 kids I gave G-Csf to, 1 less kid would have febrile neutropenia at 10 days. So I said, well, look, at 10 days, maybe it would be better if we looked at 7. So I just did the same thing again. I just whipped up the lines up the 7th day and went across, and I got 80% and 15%. And I pumped the numbers in a 2x2 table, and this time I got a number needed to treat of essentially 2, but it went all the way from 1 to 2. So to reduce febrile neutropenia at 7 days in children, I would need to treat 2 children with G-Csf to see 1 improvement. I could treat as few as 1 child with G-Csf to see 1 child get better, compared to no G-Csf, or I would have to treat 2.
But this is a better confidence interval than the previous calculation of 10 days.
Mm-hmm. So again, and you could run lines up and down and make decisions of where that cutoff point. So here I would need to treat 2 patients to see 1 get better. So for every 2 patients I invest G-Csf into, I'm going to reduce febrile neutropenia.
If we treat patient for 7 days, we can get 1 patient better
Mm-hmm.
from 2. So it's
Yeah.
better than even 10 days treatment.
Mm-hmm. So I'm going to bring that up as a secondary point, because I also looked at the secondary outcomes, which the stats weren't as good. I did the same thing again for the group. Oops. Yes, okay. And the G-Csf at the same time. Yes. I'm going to say within a population group, 50% of people recovered at 7 days, and yes, the minute they come to the hospital. So there's a febrile neutropenia in the clinic that needs to be admitted. We start the antibiotics, the doctor writes the order and and G-Csf at the same time. It's not G-Csf that you're gone home on. This is just for the episodes of febrile neutropenia. Yes. Yes. Yeah. And I'm just, like, you bring up an excellent point, because that's looking at time as a continuous variable, because time actually time goes on continuum, but what else I've done is snapshot. So I've done something called dichotomous. I've done yes, no, day 14, yes, no, day 7, day 10, yes, no. So I've converted a continuous variable into a dichotomous yes and no type variable. So I did this for neutropenia at 10 days. Again, this is a secondary outcome. And here, I would have to treat 4 patients, because we round this up, with G-Csf to see one less patient with neutropenia at 10 days. But I could treat as few as 2 patients, so for every 2 patients I treat with G-Csf, one would not have neutropenia at 10 days, or I could have to treat as many as 9 patients to get that outcome. I did the same thing with fever, the other outcome. Oh, sorry, I double-clicked. Okay, so I took fever at 7 days because I didn't know where 10 days would be here, and this stopped, so I arbitrarily chose 7. It was a difference of 8 and 6. So for fever, I would have to treat 40 patients with G-Csf compared to no G-Csf to see one better patient. And that actually, you'll notice here that the p-value is 0.944, so it's not statistically significantly a difference, but it also means I could treat 7 patients and see actually cause harm and cause one more patient to stay in the hospital or still have fever, or I could treat as few as 10. Whenever you see this happening, it essentially means that your p-value is not statistically significant, so it means you really can't use these results. There was no difference. So here's the summary of the results here. This is 38.57. So febrile neutropenia at 7 days, I needed to treat 2. Febrile neutropenia at 10 days, I needed to treat 3. Neutropenia at 10 days, I needed to treat 4. And for fever, I needed to treat 39. And here's all the p-values. So notice the strongest is at 7 days. So knowing that, and now we come back to your question, does this patient match in the study, does your patients or the patients you'd care for here match the patients in the study? And you had concerns because of the time, you had concerns because you don't know if the patients were, exactly. So you may say, that's really interesting information, Dr. Kemp, but I don't know if I can use it because I'm not sure if this really matches my patients. So you could say that. We defined what the primary and secondary endpoints were, and they did not use any surrogate endpoints. These are the primary and secondary endpoints may be surrogate because you may really be concerned about death versus not death. But in this situation, we just used the primary, which was febrile neutropenia. And the number, as I said, the number needed to treat to prevent one adverse outcome, we said was anywhere from 1 to 2, up to 4. And the question you have to ask yourself, is that worth reducing, is that worth the increased cost of using the G-Csf and maybe the risks of harm? Harm may be that you're giving a kid an injection, the psychological trauma and that. So there may be other causes there. So I just wanted to say, we looked at this article, and we have this information of the number needed to treat, and this was from a clinical case that came up yesterday morning at handover rounds, and essentially we found a quick answer. Now it's taken us a bit longer here than it would, and there's actually, if you go to TRIP database, you search this, you get this article. The second one is a quality filtered article from the University of Michigan where somebody's critically appraised and done all the calculations for you, which you could read, and it comes up as one screen. And you could read that and have the information. So you can quickly answer these questions of whether or not you should be using G-Csf. Again, this is one randomized controlled trial, and there may be more information out there. So on Wednesday, we're going to do a systematic review of the same question on children that was done by a friend of mine, Dr. Lillian Sung. And we're going to look at that document, and we're going to see, does that match up with what we're seeing here? Because this is just one study, and as Dr. Haney said from the very beginning, it's very few patients, and should I really be using those patients to guide my judgment? Well, the way to do that is to look for a systematic review. So on Wednesday, that's what we'll be moving on to. Thanks very much.